So we're now headed into this session on survivorship and dissemination. And our first speaker is Dr. Susan Lutgendorf, who's a professor in the departments of psychology, obstetrics, and gynecology and urology, and member of the Holden Comprehensive Cancer Center at the University of Iowa. Her work, sponsored by the National Cancer Institute, examines how factors like stress, depression, and social support are linked to biological processes involved in angiogenesis, inflammation, and recurrence in ovarian cancer patients. And thank you for sticking with us.
Thanks a lot. I think is this coming through?
We can hear everyone.
Oh, okay. So it's for the online folks. So I am delighted to be here today, and with all the adventures that we've gone through. And I think I just want to make a bottom line statement to start with, which is this talk really complements the kind of things that Melinda was talking about earlier, which is essentially talking about a biobehavioral, stress-induced exercise, obesity, macro environment that affects the tumor microenvironment. And what I'm going to be showing you is the various data that we have supporting that. So I just need to do this manually. Is that okay? Okay, so with respect to epidemiologic perspectives, the role of stress with respect to cancer, any cancer, or with respect to ovarian cancer, has been extremely controversial. And mostly the public belief in the role of stress has been overrated. In terms of epidemiologic perspectives, the role of stress with cancer initiation is very inconsistent. And I'm not going to go into this in detail. There's a lot more detail in the written material that I gave the committee. We know at this point that severe stressors like death of a spouse, death of a child, early life abuse seem to have the most consistent relationships with cancer initiation as opposed to other stressors. In terms of cancer progression, that is, how does cancer progress in someone who already has it, the data is much more consistent for cancer progression. And so there are studies in a number of cancers that depression, trauma, and prolonged distress are related to cancer progression. And conversely, social support in a number of cancers seems to be related to slower cancer progression or longer survival. This is an example, I don't know how well you can see it up here, you may be able to see it better in your handouts, of a paper from our lab that was published a couple of years ago, where we show that ovarian cancer patients who have higher levels of social support, and the particular kind of social support that we were looking at is social relationships. Do they feel an emotional bond with another person? Do they have someone that they can connect with? Those people had a significantly longer survival, controlling for a variety of clinical outcome factors. So one of the questions is, how do biobehavioral factors get transduced into the body? How does stress get into the body? And what you see on the upper left with the pointer that I don't have is that there are psychological factors aren't just out here floating somewhere in midair, but psychological factors are perceived by the central nervous system, interpreted by the central nervous system. We decide if we have the resources, the coping skills, to be able to handle a stressor or not. Those decisions are biological, and they have downstream consequences. For some of the sample systems that they affect are the sympathetic nervous system and the hypothalamic pituitary adrenal axis. These systems have downstream connections with receptors on tumor cells, and via these receptors affect signal transduction in the tumor cells and affect gene expression. And that downstream affects tumor behavior, including angiogenesis, invasion, progression, and ultimately it affects the clinical course of cancer. So in terms of doing assessments, we use validated We use validated quantitative assessments for things like stress, social support, depression, well-being, resilience, sleep, and coping, among other things. Depression is very common in ovarian cancer patients. In our setting, we see depression in up to 45% of patients at the time of surgery, and at 1 year post-surgery, about 21% of people are still depressed. We also see exceedingly high sleep disturbances that persist till 1 year and are not relieved with sleep medication. So I'm just going to highlight a couple of things, the behavioral effects, biological effects of social support and of depression. So we've done a variety of studies, and what we found is that social support is related to greater natural killer cell cytotoxicity in ovarian cancer patients, both in peripheral blood and in tumor-infiltrating lymphocytes. Patients with higher levels of social support have lower tumor norepinephrine. Patients with, and I'll flip it, patients with higher levels of social support have lower levels of the pro-angiogenic factor, vascular endothelial growth factor. In peripheral blood, and this slide over here shows you that in tumor, patients with higher social support have lower VEGF. Here you see the pro-angiogenic factor IL-6, which is one of the ones that turned up in one of the slides in the preceding presentation. Higher social support, lower IL-6 in peripheral blood and in ascites. In contrast, for depression, we see depression associated with poorer natural killer cell activity in tumor-infiltrating lymphocytes, with higher levels of inflammatory versus pro-cytotoxic cytokines produced by T cells. We see distress associated with higher levels of tumor-associated macrophages expressing MMP9, which is related to invasion, and to higher levels of IL-6. So as a pilot study, we wanted to see what about the patients who might be the worst off. These would be patients with high levels of depression and low social support. And if we contrasted them to people who had low depression, high social support, what would we see in terms of gene expression profiling? And this work was done in collaboration with both Anil and with Steve Cole at UCLA. So here are our high-risk, high-depression people. You see, and so they're the 5 lines up on top, and these are matched according to grade, age, histology, stage, etc. You see over 200 overexpressed genes in these high-risk people. And these genes, many of them are related to factors that are essentially favoring tumor growth. Transcription factors, extracellular matrix factors, etc. Some of the signaling pathways that are overexpressed in the depressed, low social support patients are CREB, which is related to beta-adrenergic signaling, NF-kappa B, which is related to inflammation, STAT3 and ELK1 related respectively to metastatic capacity and MAP kinase activity. And interestingly, these high risk people, high depression, low social support, had high tumor norepi, but no difference in plasma norepi. And we're in the process of replicating and extending these findings with a sample of about 100 people, in which we're seeing, when we split on high-low norepi, we're seeing changes in the epithelial mesenchymal transition in the high-risk patients. So just because I'm covering this real quickly, this could take several hours in itself, but the preclinical findings show that beta-adrenergic signaling increases tumor weight and number of nodules, stimulates angiogenesis, stimulates invasion, migration, protects tumor cells from anoecus, increases macrophage recruitment into the tumor microenvironment, stimulates the EMT, and most of these effects are blocked by beta blockers. And much of this work comes out of Anil's lab. So just to give you an example of the kind of setup of these studies, this was a 2006 study from Anil's lab where animals with orthotopically presenting ovarian tumors were subjected to 2 or 6 hours of restraint stress over the course of 21 days. And the stressed animals showed significantly increased tumor weight, number of tumor nodules. Social isolation did exactly the same thing, and these effects were totally blocked by beta blockers. So I'm going to skip this slide other than to show you that many of these beta-adrenergic pathways have been very carefully outlined, and I refer you to a paper by Steve Colin and Neil Sud if you're interested in the pathways. So next I want to talk about the HPA effects. Up till now I've been talking about beta-adrenergic effects. Glucocorticoids also have significant effects on several hallmarks of tumor progression in addition to their immunosuppressive effects. Much of this work is in breast cancer and comes out of Suzanne Konzen's lab at the University of Chicago. Glucocorticoids stimulate growth of prostate and breast cancer cells. They enhance survival, inhibit tumor cell apoptosis, inhibit the destruction of cells by chemotherapy, and relating to a talk that was done earlier today, they affect cells in the tumor microenvironment. They affect stromal cells like adipocytes and fibroblasts to create a pro-metastatic environment, and they downregulate DNA repair. So one of the interesting things we've been seeing in our ovarian cancer patients is dysregulation of the normal HPA diurnal cycle, which peaks in the morning, hits a nadir about 3 in the morning, and if here on the top line you see our ovarian cancer patients. In the middle are patients who were operated on for suspected ovarian cancer found to be benign, and in the bottom are healthy controls. We see about a 50% increase in nocturnal cortisol in our ovarian cancer patients as compared to the healthy controls. And if you look at the time of surgery, how that relates to survival, nocturnal cortisol, those patients with, I don't know where this is showing up, but on the, in the left chart, those patients with high nocturnal cortisol and those patients with a flat diurnal slope have a much higher chance of poor survival. Controlling for clinical covariates. This has been shown previously in breast cancer, in lung cancer, and in renal cell cancer. So one of the things that we think is going on here with the cortisol is that tumors produce high levels of inflammatory cytokines. Those inflammatory cytokines go via a variety of pathways, including the vagus nerve, to the brain, where they trigger the hypothalamus to try to knock down the levels of inflammation. but those levels of inflammation are very hard to knock down because they're continuous. So we see high levels of inflammatory cytokines like IL-6 accompanying this dysregulated cortisol. What happens when high levels of cytokines hit the brain are that you get a variety of vegetative symptoms like fatigue, depression, loss of appetite, lowered pain thresholds, difficulty concentrating, sleep disorders. The kind of things we get when we have the flu. You don't want to move, you can't think, you don't want to eat. And these are cytokine-induced, well-characterized effects. We see these in ovarian cancer both with elevated nocturnal cortisol and elevated IL-6. When levels of cortisol and IL-6 normalize, these kinds of symptoms normalize. And so the take-home message here is that what we may be thinking is reactionary depression may actually be, these signs of vegetative depression may actually be biologically induced or create a biological vulnerability. I'm almost done here. I want to very briefly talk about interventions, because one of the questions is, what can you do with a behavioral intervention? This is a study in early stage breast cancer patients from Mike Antoni at the University of Miami. These patients were randomized to a control group or a 10-week cognitive behavioral stress management group. And they were compared at baseline 6 months after the intervention and 12 months after the intervention. What you see here, these on the left, this is the control group, this is the intervention group. You see 12 months after the intervention started that you see an upregulation of a variety of genes. Many of these are related to a stronger cellular immune response with a corresponding downregulation of genes supporting inflammation. In terms of survival, and this has been an area of great controversy, I'll show you one study from Barbara Anderson where she had a year-long intervention with early stage breast cancer patients, and she showed a progression-free survival advantage, an overall survival advantage, and those patients who were in the intervention and did recur survived longer. I should note, on the other hand, there are a number of studies that don't show any difference at all from a behavioral intervention. And this is one of the areas that does need more research. So to summarize, what do we need to know? And I'm going to go through these relatively quickly. We need a deeper understanding of the effects of the biobehavioral macroenvironment on signaling in the tumor and in the tumor microenvironment. Are there threshold levels that we need to be aware of? To what extent are there interactions between biobehavioral, metabolic, microbiome, lifestyle, and tumor factors? What are the effects of biobehavioral factors on chemoresistance, on immunotherapy, on things like SNPs, on the emergence of SNPs? What about the role of neo-innervation, of innervation that occurs within the tumor on tumor processes? Related to intervention, are behavioral interventions effective in altering biological variables and prolonging survival? What about effects of pharmacologic interventions, such as beta blockers? Beth Carlin has done a retrospective analysis of beta blockers and found a survival benefit in ovarian cancer patients. To what extent should we be administering beta blockers? The other questions, who can benefit most? What's the best time to intervene? And priorities in terms of an agenda. Patients should be assessed for biobehavioral risk factors. And this should happen in drug trials, particularly as related to chemoresistance and immunotherapy. We need to think about multimodal interventions, not only looking at behavioral factors, looking at behavioral plus exercise, plus diet, plus adherence. plus pharmacologic interventions, looking at advocacy and dissemination, including internet and phone interventions. And I'm going to show you real briefly an internet intervention that we're doing at Iowa called Living Well, which is a 10-week internet-based conferencing intervention where people have a live conference on the internet, and they also do daily relaxation or meditation, have daily reflections, and we cover things like stress, coping, social support, meaning, etc. And I'd like to thank all the people who have worked with me, particularly Anil Sood and Steve Cole and National Cancer Institute for funding. Thank you very much.
Yeah, let's do that.
Susan, just out of curiosity, you're looking much closer at mechanisms, if that's the right way to do it. But I'm curious, have you ever looked at socioeconomic status measures relative to depression and isolation as you're talking about?
We have socioeconomic measures in our database, but we don't have a huge amount of variability. The one thing I can tell you is we've looked at our patients in Iowa who are rural versus urban, and we see greater depression and greater sleep disturbance in rural patients as opposed to urban, but we don't see biomarker differences. But it's a really good question, and that's when you're putting in factors into that priorities, that's another one that needs to be there. Yeah.
It's such great work and exciting work, whether we're going to do mindful meditation or whatever we're going to do to assess these things. But I'm always struck, the concern is how do we get this out to everyone across the country? And I know with post-traumatic stress in the armed forces, they've been working with various avatars that can be accessed online that the participants actually feel a bond for, and they've been really shown to be a quite active intervention. I didn't know whether you've been working in that area at all, or do you think that might be possible as a way to get it out of Iowa and into sort of every state of the union?
So just repeat the question.
So the question is to disseminate. So to disseminate behavioral interventions, what about things like avatars? One of the things that we found with this internet intervention, which actually I just got funded for to extend it to Seattle, to a colleague at Fred Hutchinson, and our ultimate goal is to go national with this. It seems like you can't just say, go meditate. I mean, you could, but people don't. They'll have a tape, they'll have a 5-minute tape, a 20-minute tape, but some of it has to do with assimilating a sort of lifestyle. And what we found in our first round in working with people, and I'm sure Lori's going to tell you a whole lot more about that, there's something about the bond that happens between women, even on the internet, when they can see each other's faces, that connection, and I've done this, why don't you try this? I meditated last week, you should try it too. That really seems to make some kind of difference. So given the importance of social support, I don't know that we're going to be able to do that whole thing with avatars.
I will say there's a lot of literature about these kinds of mindfulness-based stress reduction interventions in reducing symptomology of a number of different diseases. Yes. Not really in ovarian specifically that I know of has been published, but it's always a group. There's always some amount of coming together, whether it's in person or online, that makes that's part of the program.
All right, let's hold the rest of the questions until the end of the